Our next speaker is Cyndi Nickel, the CEO and founder of DxUpClose. I've had the pleasure of working with Cyndi for over 5 years now. She's been a mentor and a great friend. I'll let you be the judge, but however, it is my opinion that Cyndi's device will significantly change the face of medicine through the appropriate antibiotic use, significantly reducing associated healthcare costs and ultimately saving lives around the world. Please put your hands together and welcome Dr. John Bedolla and Cyndi Nickel.
I want to thank Seton for allowing me to be here at TEDMed Live, and I appreciate the work that I've been doing with Brian Henry. I've known him for a while. He's been a great coach and an inspiration for the company and helping us understand how much transformation can occur when you have a 1-hour antibiotic sensitivity test. I also want to thank Dr. Bedolla. He's been helping us and is the primary investigator for a clinical trial that we have planned later this year as we go to our alpha. And with both of these and Seton helping us, I mean, who could ask for better? So we're very proud to be here and we're very appreciative of this. We have a slide, I believe, that might help us out here. So let me tell you a little bit of what our diagnostic is. It is a small device. It has two components to it, a disposable and a reader. So the disposable, of course, you use and throw away. The reader's about the size of a laptop. It's lightweight, it's portable, it can go into lots of different environments. And the disposable is designed to be able to do an antibiotic susceptibility test on 6 antibiotics in parallel. And at the end of the diagnostic, a list of antibiotics that are effective against the bacteria in the patient's sample is returned to the doctor, and the doctor can use it to make a prescription and decide what antibiotic to prescribe. The sensor in this, the heart of the system, is based on an electronic sensor, and this sensor is able to detect the life signs of bacteria in a sample. So it detects the life and death of bacteria. And so when you apply an antibiotic to the bacteria, you can see the trend in an hour, be able to accurately predict the effect of the antibiotic on this bacteria. So with this technology, it was inspired by I had a focus initially, and this is how Brian Henry and I got in touch with each other, in rural medicine and home health. And I studied the trends of antibiotic resistance. And in 2002, NIH did a study where they took a look at the number of patients who returned to the doctor's office for a second and different course of antibiotics. At that time, 10% of the time the patients would come back. In 2012, 30% of the time the patients would come back. This was a vast change and rapid change in the number of antibiotic-resistant bacteria. So, John, with these trends in mind and with our device, what kind of transformations do you think you see?
This is pretty transformative, and I'll get a little bit of background on it. So when you are having a patient with an infection, you basically need to navigate that patient successfully into the future and figure out how to treat them so that they do well. Going with the navigation metaphor, there's basically 3 ways to navigate. There's dead reckoning, which is more or less that you guess and that you kind of mark your territory and then you guess again and then you look back and you guess again and you keep going. The equivalent of that in antibiotics is when you have a patient that has an infection in a particular part of the body, then you say, well, it's this part of the body, it's probably this germ, and it's probably this antibiotic I need to give. And oh, by the way, I want to make sure my patient does well, so I'm much more likely to give broad spectrum antibiotics to make sure that I cover it. So that's dead reckoning. And the next more developed level is, if you will, similar to orienting or navigating with a compass. With a compass, you have something that's built, that is validated, that works and that gives you a rough direction of where you're going, but it doesn't tell you where you are and it doesn't tell you where you're going to end up. That's the phase at which medicine is right now. So we are lucky in places like Seton to have antibiotic stewardship programs and to have a lot of data on what the germs are. So we know roughly what kind of germs we're dealing with, and we get advice from antibiotic stewardship programs. And so that's like navigating with a compass. It's rough, it's approximate, it's better than dead reckoning, but it's not really good. The best form of navigating is actually GPS, where you know exactly where you are, exactly where you're going, and exactly how to get there. How this device is transformative is it allows us to manage a patient, if you will, with GPS instead of with dead reckoning or instead of with a compass. This device is revolutionary because you will be able to, within an hour, know exactly what antibiotic you need to prescribe to the patient, and you can target specifically the antibiotic you need and not hit a broad spectrum. The phenomenon you bring up about resistance has exactly to do with the vicious cycle of antibiotics. Antibiotics, germs become more resistant to antibiotics, and therefore people prescribe more powerful antibiotics, more broad spectrum antibiotics. The germs get more resistant, you prescribe stronger antibiotics. That, in the economic terms, is called a vicious circle or vicious cycle. And there's no way to reverse it. Currently, there's no way to reverse that cycle, except for a device like this that allows you to actually treat the specific antibiotic, the specific germ.
So as the company has evolved in its life cycle, it's gotten investors, and many of those investors are urologists and also emergency room doctors. So as I'm working with the urologists, trying to understand what their issues are, they explain to me that when they see a patient, the patient usually already has a multi-resistant bacteria. They've been treated at the family physician's office, and the family physician is using dead reckoning, and this infection evolves. And they cannot perform surgery on the patient until they clear the infection. And so they are also left with a little bit of dead reckoning because they the antibiotic-resistant bacteria that the patient has is perhaps a different community than he's used to working with, but he is wants to get the right antibiotic to the patient the first time. So he shortens the patient's misery, and he also has an opportunity to get the patient into surgery sooner so he can help the patient. So they're telling me not only do they want this device, but that they wish that the family practices have this, as well as the pediatricians. They find it heartbreaking to have a child show up with a multi-resistant bacteria. So, John, is there a transformation that we could see? I mean, the urologists clearly think there are because they're investing in us, but how do you see that unfolding in the physician's office?
Well, a lot of physicians' offices, once again, they don't have the availability of a microlab, and so they really have to guess and do, essentially what we've talked about as dead reckoning. And I don't know about you guys, but I certainly don't like doing anything in medicine that has the word dead in it as a way of sort of calculating out what I'm going to do. So it's really important, too. There is this hope that there's going to be some great new antibiotic class invented, but the bottom line is that compared to cancer drugs and rheumatology drugs and all that, investment on and development of new antibiotics is pretty small. And so that, coupled with the fact that we thought, well, maybe it's a big burden for bacteria to carry around resistance. Well, unfortunately, carrying around a little plasmid that's got a couple hundred DNA chunks in it, it's light as a feather for a bacteria. It can carry resistance for everything all day long and not even break a sweat. So it's really critical to know we're sort of limited. We have a limited number of families of drugs. We have a limited number of choices within that, and we have to be smart about it. There's not some new miracle drug coming along, and the pattern is only getting worse. So I think that this is really the only way out of the vicious cycle of persistent antibiotic resistance.
So you're an emergency room doctor,
Yes.
and this patient who's, I'm kind of following his life through his process through the life of antibiotic-resistant bacteria. When they show up in the emergency room with urosepsis, what are the steps that you can take? I understand that if you can get the right antibiotic to the patient in the first hour, their outcome is substantially better.
You are correct. So outcomes are better the earlier you administer antibiotics. the choice we sometimes have is not just of a broad spectrum versus a narrow spectrum, but we have the choice within that of drugs that are very toxic. So, for example, if someone's critically ill, I have a choice between an antibiotic, say critically ill and with kidney failure, renal failure. And I have a choice between an antibiotic that, is excreted by the liver versus excreted by the kidneys. Well, I'm going to use the antibiotic that is excreted through the liver and is less toxic to the liver. So this will help you in terms of targeting specific, highly effective therapy and also help you avoid the side effects that critically ill patients frequently have. It's very useful. Furthermore, in the emergency room, we hate bounce backs. And so whenever someone goes out on an antibiotic and it fails, they have to come back, and we love to see them, but we hate for them to have to pay another copay and the additional expense and all that. What we would like to do is to be able to say, this is the antibiotics, this is going to work, and come back if you need us, and not have them have to bounce back for another round of care.
Again, thank you, Dr. Bedolla, for being up here and helping me do this talk.
You're welcome.
Thank you.